Swayam Prabha. Digital India. Educated India.
Good morning. Today's clinical anatomy lecture is on the topic inguinal hernia. I am Professor Dr. Kalpana Ramachandran. I head the Department of Anatomy, Sri Ramachandra Medical College and Research Institute, Sri Ramachandra Institute of Higher Education and Research, Chennai. First, let us look at the objectives of this session. At the end of this lecture, you should be able to define inguinal hernia, differentiate direct from indirect inguinal hernia, discuss the anatomical basis of inguinal hernia, and you should be able to correlate the anatomical knowledge with the given clinical case. So, the outline of this lecture is that we are going to divide this lecture into various segments. We start with a case study on inguinal hernia, then go on to discuss the relevant gross anatomy of inguinal canal. Then will be the clinical features of inguinal hernia, followed by the clinical case study discussion, and we will close with a summary. Before we go into the details of inguinal canal, the quote by Sir Ashley Paston Cooper is that no disease of the human body belonging to the province of the surgeon requires a better combination of accurate anatomical knowledge with surgical skill than hernia in all its varieties. Sir Ashley Paston Cooper was a British surgeon and an anatomist, and this is quite relevant to this lecture. We will just begin with a case study. This is a case of a 70-year-old male who was seen in the surgical OPD by a consultant. The patient came with a history of chronic bronchitis and constipation. The patient complained of a gradually increasing swelling in his left groin, which I am pointing out. He also complained that he feels dragging and aching sensation at that site. Surgeon on examination found out a globular lump above the left pubic tubercle that expanded on coughing. The surgeon reduced the swelling manually and he occluded the deep inguinal ring with his thumb and asked the patient to cough. The swelling reappeared medial to the thumb. The doctor made a diagnosis of dash. At the end of this lecture, you will be able to make the diagnosis of this case. So, next segment is on the relevant gross anatomy of inguinal canal. So, this inguinal canal is a musculo-aponeurotic tunnel. To understand the inguinal canal, first let us understand the picture which is shown here. This is a picture of the lower part of the anterior abdominal wall. You can see the various layers of the anterior abdominal wall. The outermost is the external oblique muscle and the aponeurosis of the muscle. Then is the internal oblique muscle and its aponeurosis. Innermost will be the transversus abdominis and its aponeurosis. Deep to it lies a fascia. This fascia is called, what I am pointing out is called fascia transversalis. Deep to it lies the extraperitoneal connective tissue and deep to it lies the peritoneum. So, we go from superficial to deep. The layers of the lower part of the anterior abdominal wall, skin, superficial fascia is not shown in this picture, followed by external oblique muscle and its aponeurosis, internal oblique muscle and its aponeurosis, transversus abdominis and its aponeurosis, fascia transversalis, extraperitoneal connective tissue and the peritoneum. You can see the external iliac artery continuing as a femoral artery into the thigh. So, the inguinal canal is a musculo-aponeurotic tunnel. It is an intermuscular passage. So, it is going to extend from the deep inguinal ring to the superficial inguinal ring. It's about 3.75 centimeters long and 1 centimeter wide. So, the deep inguinal ring, as I am pointing out, is a opening in the fascia transversalis, which is situated about 1.25 centimeters above the mid-inguinal point. The superficial inguinal ring, you can see here, through which the spermatic cord is coming out. The superficial inguinal ring is a triangular opening in the aponeurosis of external oblique muscle. So, this intermuscular passage or the musculo-aponeurotic canal, what you are seeing, which is oblique, what I am pointing out is the inguinal canal. Females have a narrower canal. So, why is that there is a inguinal canal in the lower part of the anterior abdominal wall? This is developed because this is the passage for the descent of the testis into the scrotum. So, let us understand few things about the descent of the testis to understand why inguinal canal is developed. In this picture, you can see the descent of the testis. You can see the layers in the anterior abdominal wall, the layers, 3 layers of muscle. Testis is going to develop in the abdomen retroperitoneally. From the abdomen, it has to traverse the anterior abdominal wall and finally it has to reach the scrotum. So, the passage through which it is going to pass is going to become the inguinal canal in the lower part of the anterior abdominal wall. As it descends, you can see from the picture that it is going to drag a pouch of peritoneum, and this pouch of peritoneum is called as the processus vaginalis. So, in this picture you can see that the testis is descending into the scrotum. This is the scrotal sac. When it descends, it is also dragging a pouch of peritoneum, which we call it as processus vaginalis. So, what happens is that this processus vaginalis is going to get obliterated. The communication with the peritoneal cavity is obliterated. A part of this persists around the testis and it is going to form what is called as, what is this covering around the testis, it is called as tunica vaginalis. Otherwise, the connection to the peritoneal cavity is cut off or it is obliterated. Suppose this connection persists, there is going to be a preformed sac, so that abdominal contents are going to herniate into the scrotum. So, this can persist at times and it is called as persistent processus vaginalis, and this is the reason for the indirect inguinal hernia. We will understand this better in the further slides. So, as I have already mentioned, you have a superficial inguinal ring and a deep inguinal ring, and extending between both will be your inguinal canal with a length of about 3.75 centimeters long. So, in this picture you can see that this is the rectus abdominis muscle. This is the pubis, pubic bone, body of pubis. This is anterior superior iliac spine, and you can see here the inguinal ligament, which is going to extend from the anterior superior iliac spine to the pubic tubercle. In this picture, the layers of muscle and aponeurosis in the anterior abdominal wall is shown: external oblique, internal oblique and transversus abdominis. So, in the external oblique aponeurosis, you can see a triangular canal, triangular ring, which is called as a superficial inguinal ring, through which the spermatic cord is emerging. So, this superficial inguinal ring lies 1.25 centimeters above the pubic crest. This is above and lateral to the pubic crest. This is your superficial inguinal ring. If you take the deep inguinal ring, this is an opening in the fascia transversalis. This structure is the fascia transversalis, in which you can see the deep inguinal ring, which is about 1.25 centimeters above the mid inguinal point. So, this is about the deep and superficial inguinal rings. This is the superficial inguinal ring and this is the deep inguinal ring. Extending between both is the inguinal canal, which is 3.75 centimeters long. So, now we will look at the boundaries of inguinal canal. So, in the further slides, we are going to discuss about the boundaries. This is the inguinal canal, the oblique passage or the intermuscular passage. So, you have an anterior wall for this, posterior wall, then you have a roof and a floor. We are going to look at the various boundaries in detail. So, looking at the anterior wall, as you can see from this picture, the skin and superficial fascia is the outermost layer, followed by you have the aponeurosis of external oblique muscle, aponeurosis. In the lateral 1/3, you have the fleshy fibers of internal oblique, So, anterior wall is formed by skin, superficial fascia, external oblique aponeurosis and then lateral 1/3 by the fleshy fibers of internal oblique. Now, we will look at the posterior wall of the inguinal canal. This is the posterior wall of the inguinal canal. In its whole extent, the posterior boundary is formed by the fascia transversalis, extraperitoneal connective tissue and the peritoneum. In the medial 2/3, the posterior boundary is formed by conjoint tendon. What is this conjoint tendon? Conjoint tendon is formed by fusion of lowest aponeurotic fibers of internal oblique and transversus abdominis. This is the internal oblique aponeurosis, this is transversus abdominis aponeurosis. So, this forms the conjoint tendon which forms the posterior boundary for the posterior wall for the inguinal canal. Suppose there is a weakness of the conjoint tendon, contents of the abdomen can herniate can push through the posterior wall and can herniate out. Patient will present with the swelling in the groin. So, that becomes direct inguinal hernia. So, this is the posterior wall. Coming to the roof, you can see that it is formed by arched fibers of internal oblique and transversus abdominis. Floor, you can see, is formed by the inguinal ligament, which is its upturned part of the inguinal ligament. So, you have an anterior wall, posterior wall, roof and also a floor for the inguinal canal. So, coming to the contents of the inguinal canal, you can see that the canal is traversed by the spermatic cord in case of males. In case of females, you have the round ligament of uterus. Other than this, there is a nerve which is present, which is the ilioinguinal nerve, which is not a through and through content, but enters the canal after piercing the internal oblique muscle and leaves through the superficial inguinal ring. So, these are the contents of the inguinal canal. To understand the hernia, direct and indirect inguinal hernia, it is very important to understand a triangle which is present here, which is a surgically defined zone through which direct inguinal hernia occurs. This is called as Hasselbalch's triangle. So, let us again look at this picture. As I have already mentioned, this is the rectus abdominis muscle. This is the body of pubis, pubic crest, lateral end of which is the pubic tubercle. This one is the inguinal ligament extending from anterior superior iliac spine to the pubic tubercle. So, here you have the external iliac artery and you can see an artery running here towards the rectus abdominis, that is your inferior epigastric artery. So, this Hasselbalch's triangle is bounded medially by, this is medial and this side is lateral, medially by the lateral border of rectus abdominis, laterally by the inferior epigastric artery and below is the inguinal ligament. So, this triangle through which direct hernia occurs is called as Hasselbalch's triangle. It is very important to note certain relations here. One is that the deep inguinal ring, the stem of the deep inguinal ring is going to lie lateral to the inferior epigastric artery. This is the inferior epigastric artery, and you can see that the deep inguinal ring lies lateral to the inferior epigastric artery. So, this is Hasselbalch's triangle through which direct inguinal hernia occurs. Next, we will look at the clinical features of hernia. So, first let us define what is hernia. Hernia is an abnormal protrusion of a viscus, which is an hollow organ, or a part of it through an abnormal opening in the wall of its containing cavity. So, now we look at what is inguinal hernia. Inguinal hernia is protrusion of an organ through the wall of the cavity, that is through the inguinal canal that normally contains it. So, this inguinal hernia can be congenital or it can be acquired. So, we look at the further details in the next few slides. So, this is the intestine protruding through the inguinal canal. So, there are two types of inguinal hernia. One is called oblique or indirect hernia, another one is called as direct hernia. Again, we look at the same picture. You can see this is a bowel loop and this is the inguinal canal, and you can see that the bowel loop is protruding through the inguinal canal, coming out through the superficial inguinal ring. So, any hernia passing through the deep ring, through the inguinal canal, coming out through the superficial inguinal ring, this is called as indirect hernia or oblique hernia, or indirect hernia passes through the inguinal canal. Direct inguinal hernia protrudes through the posterior wall of the inguinal canal. This is the posterior wall of the inguinal canal, which we already understood that in the medial 2/3 is formed by the conjoint tendon, that is the lowest aponeurotic fibers of internal oblique and transverse abdominis. So, if there is going to be weakness in the conjoint tendon, there can be protrusion of the abdominal contents through the posterior wall of the inguinal canal. As we have already read and understood, this region is the Hasselbalch's triangle. You have the lateral border of rectus abdominis, inferior epigastric artery and the inguinal ligament. This region is going to be your Hasselbalch's triangle. So, if the contents, intestine or any other content is going to protrude through the posterior wall of the inguinal canal, that is through the Hasselbalch's triangle, it is going to be direct hernia. Please understand that direct hernia is medial to inferior epigastric vessels. This is inferior epigastric vessels. Intestines protruding medial to it, it is going to be a direct inguinal hernia. As already mentioned, the deep ring is going to be lateral to the inferior epigastric artery, and any content passing through the deep ring, inguinal canal and through coming out through superficial inguinal ring, it is going to be your indirect inguinal hernia. So, the inferior epigastric artery is a important landmark. So, the coverings of the hernial sac change depending upon where the herniation occurs. So, as I already mentioned, you have a indirect inguinal hernia and direct inguinal hernia. Indirect inguinal hernia is going to pass through the inguinal canal, and your direct inguinal hernia is going to take a short route. It is going to directly protrude through the superficial inguinal ring, pushing against or around the conjoint tendon. The conjoint tendon can be weak. So, these are the two types of inguinal hernia. To understand further, we need to understand the hernia composition. This is the hernial sac. So, you can see that sac is nothing but a pouch of peritoneum. It has got a mouth, this region is the mouth. It has got a narrow part which is called as the neck, and it has got a body. This is the body of the hernial sac, and this is going to be the fundus of the hernial sac. The hernia itself has got various coverings. It is derived from the layers of the abdominal wall. and it has got a content. You can see here a loop of ileum. It can be a momentum, then it's called as omentocele. If it is intestine, it is called as enterocele. It can also be herniation of ovary or urinary bladder. Hence, hernia has got a sac, it has got a covering, and it has got a content inside. This is what is the composition of a hernia. So, why is inguinal hernia occurring? We should know the cause, that is called as the etiology of inguinal hernia. So, any condition that raises the intra-abdominal pressure is a predisposing factor for occurrence of inguinal hernia. First is whooping cough in children. Patient can have chronic bronchitis where he keeps coughing. Straining on micturition, certain conditions, clinical condition causes straining on micturition, straining on defecation, obesity, lifting heavy weights. These are the predisposing factors for occurrence of hernia because there is going to be rise in the intra-abdominal pressure. Coming to the clinical features, what does the patient present with? The patient presents with pain or discomfort or dragging sensation in the lower part of the anterior abdominal wall. This is the umbilicus and this is the lower part of anterior abdominal wall. He can have a swelling in the groin, that is the inguinal region, which increases in size. Sometimes if you take a past history, he might give a history of appendicectomy. There can be damage to ilioinguinal nerve, there can be weakness of abdominal muscles in this case. So, as already mentioned that there are two types of inguinal hernia, indirect and direct inguinal hernia. First, we look at the indirect inguinal hernia. As has been explained earlier, indirect inguinal hernia is usually congenital because of persistence of processus vaginalis. The processus vaginalis is a pouch of peritoneum which is dragged with the descent of the testis, which usually obliterates, and the connection to the peritoneal cavity is cut off, and it is going to form a covering of the testis that is called as tunica vaginalis. Suppose this communication remains patent, that is the communication is still there, the abdominal contents can directly pass through the into the scrotum. So, you can see that in indirect inguinal hernia, the cause is usually congenital because of persistent processus vaginalis, which should obliterate but remains there. So, that is the cause of indirect inguinal hernia. So, there are types of indirect inguinal hernia. One is incomplete, another one is complete. Complete means it is called vaginal or scrotal, where it is extending the herniated contents extend till the bottom of the scrotum. It is called inguinoscrotal hernia. Sometimes it is incomplete, it can be limited, it can be in the inguinal canal only, it is called bubonosele. If it is limited just above epididymis, it is called funicular. These are the types of incomplete indirect inguinal hernia. So, indirect inguinal hernia, you must understand that coverings are same as the coverings of the spermatic cord plus peritoneal sac and extraperitoneal connective tissue. The most important point to be noted is that the inferior epigastric artery, what I am pointing out is the inferior epigastric artery is medial to the neck. This is the neck of the hernial sac, this is the loop, this is the sac of or pouch of peritoneum. So, the inferior epigastric artery is medial to the neck of the hernia. So, that is for indirect inguinal hernia. So, let us look at the coverings of the indirect inguinal hernia. You can see that this is the pouch of peritoneum, extraperitoneal connective tissue. Then you have internal spermatic fascia which is derived from the fascia transversalis. Then you have the cremasteric fascia which is going to be derived from the internal oblique and transversus abdominis. Then outermost will be your external spermatic fascia which is going to be derived from the external oblique aponeurosis. Then is the superficial fascia and the skin. These are the coverings of the indirect inguinal hernia. As has already been mentioned, a hernia has got a sac, it has got a content, it has got a covering. Those are the things which has been described. Coming to direct inguinal hernia, this picture on the left is showing a dissection of the inguinal region, which is an internal view. We are looking at the anterior abdominal wall from the inside. And what you are clearly seeing is the Hasselbalch's triangle, which is a green color triangle which is shown in this picture, bounded by the inferior epigastric artery, lateral border of rectus abdominis and the inguinal ligament. There is a medial umbilical fold which is going to divide this Hasselbalch's triangle into a medial part and lateral part. As has been mentioned, this Hasselbalch's triangle is a triangle through which direct inguinal hernia is going to occur. So, this herniation through the posterior wall is the reason for direct inguinal hernia, where there is going to be weakness of the conjoint tendon. So, this medial umbilical fold, which is raised by obliterated umbilical artery, divides the direct inguinal hernia into a medial direct inguinal hernia and a lateral direct inguinal hernia. The most important thing is the inferior epigastric artery. What you are seeing here is the inferior epigastric artery is going to be lateral to the neck of the hernial sac. The hernia is going to be in this triangle. Inferior epigastric artery is lateral to it. So, this again, the direct inguinal hernia, as I told you, can be divided into medial and lateral direct inguinal hernia. So, if you look at the medial, this is the region where the direct inguinal hernia occurs. It is occurring through the posterior wall of the inguinal canal, where the conjoint tendon is weak. This itself will be divided into medial part and lateral part. So, it is occurring through the Hasselbalch's triangle. So, medial direct inguinal hernia, the coverings will be peritoneum, extraperitoneal connective tissue. You have the fascia transversalis. Then you have the conjoint tendon. What you are seeing here is a conjoint tendon. Then you have the external spermatic fascia, Then will be it is extending to the scrotum, that is called complete hernia, where you have the dartos and the skin. So, this is the coverings of the medial direct inguinal hernia. Then you have lateral direct inguinal hernia. Again you have peritoneum, coverings will be peritoneum, extraperitoneal connective tissue. You have the fascia transversalis, note the difference from the indirect inguinal hernia. Then you have the cremasteric fascia, which is going to be derived from the internal oblique and transversus abdominis, external spermatic fascia, which is going to be derived from the external oblique aponeurosis. Then when it descends into the scrotum, you have dartos and the skin. So, this is lateral direct inguinal hernia coverings. So, we will just look at the summary of the difference between direct and indirect inguinal hernia. Direct inguinal hernia is common in children and young adults, but direct is common in case of elderly persons. Indirect inguinal hernia, 2/3 of the cases are usually unilateral, but direct more than half cases are bilateral. Here in indirect inguinal hernia descends obliquely downwards and medially. It is going to pass through the inguinal canal. Here in case of direct hernia appears as a forward bulge. It is going to occur through the Hasselbalch's triangle. Indirect inguinal hernia is usually reduced by the doctor, and direct hernia reduces when the patient lies down. The most important thing is, if you do a ring occlusion test, you push the contents into the abdomen, close the deep inguinal ring, ask the patient to cough. If there is going to be a bulging which is appearing medial to the finger, it means that it is not passing through inguinal canal, it is coming out through the Hasselbalch's triangle, and then it is going to be the direct inguinal hernia. So, in ring occlusion test, in indirect inguinal hernia, on occluding the deep inguinal ring, hernia does not bulge out. So, it is understood that indirect inguinal hernia occurs through the inguinal canal and direct hernia is through the Hasselbalch's triangle. And as has been already said, neck of the sac in case of indirect inguinal hernia is lateral to inferior epigastric artery. And here neck of the sac is medial to inferior epigastric artery. So the cause is usually due to, in case of indirect inguinal hernia, as I have already mentioned, is because of the persistence of processus vaginalis. And in direct inguinal hernia, it's usually acquired due to weakness of weakness of conjoint tendon. And if you look at indirect inguinal hernia, the spermatic cord is lying below the sac. And in case of direct inguinal hernia, spermatic cord is pushed laterally. So these are the differences between indirect and direct inguinal hernia. Now let us look at the examination findings. Once you examine the patient, there is cough impulse in case of inguinal hernia. That is, when the patient coughs, the hernia appears more prominent. So this is called as visible and palpable cough impulse. It reappears on straining, standing or coughing. But cough impulse may not be present if neck of the sac is blocked by adhesions. So this is one important examination finding in case of inguinal hernia. Next is reducibility. Usually the patient himself will reduce the swelling. But if the doctor has to reduce, the patient has to lie down, and the thigh should be of the affected side should be flexed, adducted and internally rotated. And finger should guard the inguinal canal by thumb and index finger, and scrotum is squeezed gently so that the contents can be pushed into the inguinal canal. That is manual inguinal hernia reduction, that is called as reducibility test, which is seen in inguinal hernia. The most important thing is the relation to pubic tubercle. If you look at this picture, this is the inguinal ligament, this is the midline and this is the umbilicus, this is the pubic crest and this is the pubic tubercle. The neck of the inguinal hernia is above and medial to the pubic tubercle. But in case of femoral hernia, neck is below and lateral to the pubic tubercle, and this will be below the inguinal ligament. This is the relation to the pubic tubercle. You can get above the swelling in case of pure scrotal swelling, but in case of inguinal hernia, you cannot get above the swelling. This is done by, in standing position, at the root of the scrotum, place the thumb in front and index finger behind, try to reach above the swelling. Inguinal hernia, you cannot get above the swelling. So that is next finding which you will see on examination. Next is ring occlusion test, as has been already explained. You should reduce the hernia, occlude the deep ring and ask the patient, holding the thumb in by occluding the deep ring, ask the patient to cough. If there is going to be bulging medial to the occluded finger, then it becomes direct hernia. If there is no bulging, it is the indirect inguinal hernia. These are the examinations which you can do in case of indirect and direct inguinal hernia. So the treatment for this is, one is herniotomy. You can reduce the hernial contents, ligate the neck of the sac and excise the redundant peritoneum. This procedure is called herniotomy. Another procedure is your herniorrhaphy, which includes herniotomy, and you can repair the deep inguinal ring. That is called as herniorrhaphy. One more is the mesh repair of the posterior wall of the inguinal canal, that is called hernioplasty, where you do a herniorrhaphy plus you can strengthen the posterior wall of the inguinal canal by using a mesh, that is called as hernioplasty. These are the treatment for inguinal hernia. So we are coming to the segment 4, where we will discuss the clinical case which was shown earlier. So the diagnosis of this case is that it is direct inguinal hernia because On ring occlusion test, the swelling appeared medial to the finger and hence it is direct inguinal hernia. What will be the relation of the sac to the cord? The cord, spermatic cord, is pushed laterally by a direct inguinal hernia. What is the relationship between the swelling and the pubic tubercle? As has been explained earlier, the swelling will appear above and medial to the pubic tubercle. This is very important because you have to differentiate a inguinal hernia from a femoral hernia which appears through the femoral canal. So, that is going to be below and lateral to the pubic tubercle. What is the relationship between inferior epigastric artery and the neck of the hernial sac in this case? This is a case of direct inguinal hernia. So, the neck of the sac will be medial to the inferior epigastric artery. What is falx inguinalis? That is called as conjoined tendon. And how is it related to direct inguinal hernia? Conjoined tendon, I told you, is forming the medial two-third of the posterior wall of the inguinal canal, that is called as conjoined tendon, and if it is weak and there can be a weakness of the posterior wall of the inguinal canal and direct inguinal hernia can occur through the Hasselbalch's triangle. So, this completes the clinical case discussion. So, we are closing this lecture on inguinal hernia with a summary. I will summarize the difference between indirect and direct inguinal hernia because of its importance. The indirect inguinal hernia is common in children and young adults. On the contrary, direct is common in elderly. Indirect inguinal hernia, two-thirds of the cases are unilateral. In case of direct, half of the cases are bilateral. Hernia in case of indirect inguinal hernia descends obliquely downwards and medially because it is going to occur through the inguinal canal. But direct inguinal hernia is going to appear as a forward bulge. It usually occurs through the Hasselbalch's triangle. Ring occlusion test, if there is going to be a bulging medial to the occluded finger, it is going to be direct inguinal hernia. And on occluding the deep ring, if the hernia does not bulge out, it is going to be indirect inguinal hernia. Neck of the sac of indirect inguinal hernia is lateral to inferior epigastric artery in case of indirect inguinal hernia, and in direct inguinal hernia, neck of the sac is medial to inferior epigastric artery. The cause, as is obvious, it is acquired due to weakness of conjoined tendon in direct inguinal hernia, and cause in case of indirect inguinal hernia is because of the persistence of processus vaginalis, which usually is obliterated. And the spermatic cord is pushed laterally in case of direct inguinal hernia, and in case of indirect inguinal hernia, the spermatic cord lies below the sac in case of indirect inguinal hernia. Thank you.